Welcome to the lecture on upper gastrointestinal problems. So today we're going to talk about 4 different sections that are part of your book. Make sure not to read extra, look at your page numbers, but you should be focused on nausea and vomiting, gastroesophageal reflux disease, also known as GERD, peptic ulcer disease, also known as PUD, and upper GI bleed. Nausea and vomiting is the most common manifestation of GI diseases. It's also one of the main reasons that people visit the emergency room as well. Nausea really is the feeling of discomfort in the epigastric area with a conscious desire to vomit, and then that can actually lead to vomiting. When it comes to the etiology and the pathology, vomiting can occur when the GI tract becomes irritated, excited, distending. Vomiting can be a protective mechanism of getting rid of extra acid or something that you're not supposed to have in your system. And it can be a side effect for issues like pain or different medications. So our goal is really to treat the underlying cause if at all possible. For example, with pain, give pain meds and the patient's nausea and vomiting will sometimes subside. Sometimes those pain medicines can cause the nausea and vomiting, so it really can go round circle. Clinical manifestations, vomiting. There is a threat of pulmonary aspiration. It is one of the highest concerns if they aspirate their vomit. Prevention of aspiration is putting the patient on their side or maybe the semi-Fowler's position. And then an elderly or unconscious patients, they are really the highest risk. So those are the people that we're going to watch for. For example, people that are coming out of surgery are a big issue, all those kind of things. So we're going to watch for pulmonary aspiration. Other concerns really can include metabolic alkalosis, which we'll cover more in a different section, or metabolic acidosis, which is the loss of bicarb from the vomiting. So that's important to remember for later in Unit 2. So when we're determining the source of nausea and vomiting, we really want to look at some specific things. For example, color and odor. Vomitus with a coffee ground appearance, that's usually a sign of gastric bleeding. Blood changes it to dark brown, which results of its irritation with hydrochloric acid that occurs in the stomach. Bright red blood usually indicates a active bleeding, so something above the stomach. You can have bile, dark green. You can have fecal odor, which usually is a sign of intestinal obstruction. You can have food contents, so that's really important to look at. Then you really should look at timing. Is it right after they eat? Is it hours after food is ingested, but there's still partially digested food in there? That can usually be a sign of like gastric outlet obstruction or delayed gastric emptying. Usually early morning vomiting is a frequent occurrence in things like pregnancy, although really with pregnancy, it's not just early morning, it could occur at any time, it just can be more frequent in the morning. Is there emotional stressors? Really with no evident pathological disorder. This may elicit vomiting during or immediately after eating. Bright red blood indicates active bleeding. This is an emergency. You can have something called a Mallory-Weiss tear. This is a disruption of the mucosal lining near the esophageal junction. There will be a picture on the next slide that talks about it. Is it esophageal varices? This is a medical emergency if they're bleeding because we'll talk about more in different sections. These are high bleeds that can really cause a lot of issues. Or is it a gastric or duodenal ulcer? A Mallory-Weiss tear is a tear in the mucosal layer at the junction of the esophageal and the stomach. It is often related to severe retching and vomiting. So somebody that either causes a lot of vomiting, has a history of a lot of vomiting, they can get these Mallory-Weiss tears. This is a picture of esophageal varices. You can see that at the very top there is kind of like a varicose vein, but it's in the esophagus. But when it starts bleeding, it really will bleed. Drug therapy for nausea and vomiting, really focus on there's a table in your book that talks about all the meds. Really, the ones that are highlighted on this slide are your responsibility. There's a lot of meds in your book, but really use your book in conjunction with this. Drug therapy depends on the cause of the problem. Antiemetics act on the CNS in what's called the CTZ or receptor trigger zone, which blocks the neurochemicals that trigger nausea and vomiting. So we're trying to block the CTZ to keep people from vomiting. Some examples, anticholinergics. This could be like a scopolamine patch that is put on the back behind the ear. This can be worn up to around 72 hours. A lot of times surgeons with know that people have a lot of nausea and vomiting, the anesthesiologist will put a scopolamine patch, or a scope patch you might hear it called, and have them wear it after surgery to help control their nausea and vomiting. So some other meds include antihistamines. This could be like Dramamine, which you can get over the counter for people that get nausea and vomiting while getting motion sickness. You can have Phenergan, Vistaril. Then you have the promethazines, which can include Compazine. Most of these can be very hard on the veins when given IV. Really, they've kind of gone to not even giving certain meds such as Phenergan IV. It should be diluted and given in the IV slowly on a pump, never given in the back of hand. You want to make sure you have really good access, but most places are going to just really Phenergan IM, for example, instead of IV, because there's been such issues with it. So the prokinetics, remember kinetic means movement. The big one is Reglan. This increases gastric emptying. So if they have a lot of issues with backup of gastric contents, this Reglan will really help with the gastric emptying. But the side effects for some people is tremors, which can be pretty big for some people. Serotonin agonists such as Zofran. Zofran is probably one of the most common given. Dexamethasone or Decadron is usually managed for like chemotherapy-induced emesis. The people who are on chemo with those emesis can really cause a lot of issues. So sometimes they will just schedule Decadron and other meds like around the clock, such as Reglan. Another one that's given is Marinol. It's usually an orally active cannabinoid used alone or in combination with other antiemetics. So really, what are we going to do as a nurse management of these patients? Acute intervention, we're going to assess for dehydration, right? Somebody that's been nausea and vomiting for a long time, they're going to have really dehydration issues. So do we need IV access? Because do they need IV fluids for that kind of hydration? We're going to watch their intakes and outputs. We're going to monitor vital signs that's going to help tell us for dehydration. The possibility of an NG tube with suction may be used for possible like obstructions or issues. Usually a patient is NPO status until we can know what is going on, and we're going to give IV fluids, because you don't want to, if somebody's got, for example, a tear in their esophagus, you don't want them to eat and irritate that. So we're going to make them NPO, give them IV fluids. NG tube also might be like needed if they're persistent vomiting, bowel obstruction, paralytic ileus is suspected. That's where their gut is literally not moving. Secure the NG tube to prevent its movement in the nose and the back of the throat, because that can stimulate nausea and vomiting. So we're going to secure it, as you can see in this picture, to the nair. Make sure the tube is actually checked. So you want to, every time you walk in, make sure that NG tube is still in the correct position. Nutritional therapy, really IV fluids is the goal to replace fluid and electrolytes and glucose. The clear liquids are usually given orally if everything has been cleared so far. That is our next step. And then we advance diet as tolerated, really high carb, low fat foods. So examples, baked potato, plain gelatin, broth, cereal, cooked chicken, and we're going to have them eat slowly and in small amounts. One of the things that we give a lot of people is like Jell-O, and you don't want to give them, for example, red Jell-O, because that can be a sign of bleeding. So now we're going to talk about GERD, or gastroesophageal reflux disease, a very common problem for a lot of people. It's usually a chronic manifestation of mucosal damage. So this is not something you're going to see the first time. This is long-term chronic issues. Usually it's caused by a reflux of gastric contents into the lower esophagus that causes that kind of burning sensation. Etiology and pathology. It's an incomplete, what we call LES, or a lower esophageal sphincter. Sphincters are supposed to be tight, and it really is to control movement of substance and prevent backflow. So an incompetent LES is going to allow for the backflow of substances and acid. Primary factor in GERD results in lower pressure in the distal portion of the esophagus, so gastric contents move upward from the stomach into the esophagus. If you remember, acid contents in the stomach, very, very acidic, and so it's not supposed to be in the esophagus, which causes that burning and can cause some issues. Can be due to certain like foods such as caffeine and chocolate, or drugs that are used long term such as anticholinergics. So as you can see on the image on the left, the sphincter is tight, closed as it should be after food has moved past it. The image is really how LES should function ideally, right? That sphincter closes, it doesn't allow for any kind of backflow from the acid. The image on the right is the LES is too relaxed, and it's allowing those gastric contents to move upward. Causes, obesity is a big risk factor. Pregnant women are at increased risk because it is, the baby is pushing up, causing the acid to go back up into the esophagus. Chocolate and caffeine, cigarettes and cigar smoking. Hiatal hernias are also a very common cause, so that hernia is putting pressure on the esophagus, which is causing that backflow. Clinical manifestations, one of the first is heartburn. Usually people start off with like mild symptoms like heartburn after a meal. Maybe it occurs once a week or something like that. That's kind of the beginning steps. Heartburn is the most common clinical manifestation. It's also known as pyrosis. It is a burning, tight sensation beneath the lower sternum and spreading upward through the throat or jaw, and it's felt intermittently. We'll talk about this a little bit later, but one of the biggest things that people will complain of is that lower sternum pain. And so when they come in through the emergency department, is this pain a heart attack, or is this pain heartburn or dyspepsia, which we'll talk about too? So a lot of times they will have to figure out, man, is this cardiac related or GI related? Cardiac is obviously a higher emergency, so they'll do things like EKGs, or sometimes if the EKG looks fine, they'll give meds that will help with acid reflux, and if that helps, they're like, oh, it's more GI related. Dyspepsia, pain or discomfort centered in the upper abdomen, and regurgitation, which is described as a hot, bitter, or sour liquid coming into throat or mouth. The individual may also report like respiratory symptoms or long-term otolaryngal symptoms. This is due to the irritation up the upper airway by gastric acid contents. So the acid's backing up so far that it's going up the esophagus, down the trachea, and causing respiratory issues. So you'll see wheezing, coughing, dyspepsia, dyspnea, hoarseness, sore throat, lump in the throat, choking. Really, it's a potential for like chronic asthma, bronchitis, pneumonia, especially if the patient aspirates, which is a big issue. So like I was saying, GERD-related chest pain, it's described as burning, squeezing, or radiating to the back, neck, jaw, or arms. This really mimics angina, which is that chest pain. Really, angina is, or like the chest pain is relieved with antacids. It's GERD-related. So chest pain is the most common in older adults with GERD, and GERD-related chest pain is relieved with antacids. Collaborative care, lifestyle modifications. We're going to teach these people what diet and drugs affect the LES, the acid secretion, the gastric emptying, and we're going to encourage them to avoid those triggers. That is hard with some people who maybe, so for example, cigarette, chocolate. Let's say chocolates. If I like to eat chocolate every day because it is a stress relief for me, I'm not going to stop taking or eating chocolate, so I'm going to need somebody to help me learn how to change those kind of cravings and those triggers. So nutritional therapy, this is a big one. So decrease high-fat foods, take fluids between rather than with meals, avoid milk products at night, and avoid late-night snacking or meals. It's important when you're hearing all these nutritional therapies, like for example, avoiding chocolate, peppermint, caffeine, tomato-based products, orange juice, red wine, or alcoholic beverages. It is important in your exam and in your nursing career that if it says, hey, what, for example, a patient is saying, hey, these are the things I've changed, and one of these triggers isn't addressed, then you need to be focused on that. So take time to really study the slide and study what they should avoid diet-wise. Additional teaching methods. This is also extremely important for your exam. Increase the head of bed greater than 30 degrees. Not lying down for 2 to 3 hours after eating. Avoiding of late night eating, and weight loss. Weight reduction therapy and chewing gum and oral lozenges really can increase saliva production and help patient with mild symptoms. Drug therapy for GERD. One of the big ones is PPIs, proton pump inhibitors, and H2R blockers. These are the most common and effective. So H2R blockers are histamine-related blockers. Focuses on decreasing the volume, decreasing the acidity of reflux, and increasing esophageal clearance, which really is protecting that esophageal mucosa. So proton pump inhibitors, PPIs, one of the examples, omeprazole, usually they're indenzole. This could be like Prilosec, which you can get over the counter actually. It promotes esophageal healing, decreases incidence of esophageal strictures, but the side effects really for long-term use and high doses are increased risks of fractures, especially in the hip, wrist, or spine. So if you have a patient that is a high fall risk or maybe elderly, that's something you really should consider, maybe like shorter doses, maybe shorter duration of therapy. And PPIs are also associated with increased risk of C. diff infections in hospitalized patients, which we'll talk about C. diff later, but that is something to remember for when we talk about C. diff. So histamine 2 receptors, or H2R blockers, an example of this is cimetidine, and a lot of these are N-N-D-I-N-E, such as cimetidine, ranitidine, famotidine, which a big one is Pepcid. And so really remember that the generic names N-N-D-I-N-E. These decrease secretions of the hydrochloric acid and reduce symptoms and promote esophageal healing. Side effects really are uncommon. It's available over the counter in a lot of ways, or prescription forms. Usually the over-the-counter preparations have lower drug dosages than the prescription drugs. So if the over-the-counter is not meeting what they need, they'll kind of go to the prescription route. Some formulations include an H2R blocker plus antacid combination. So for example, this could be Pepcid Complete, which is famotidine, calcium carbonate, and magnesium hydroxide. The cholinergic, this could be an example of the methanochol. These increase LES pressure, improve esophageal emptying, and increase gastric emptying. So another drug therapy is the prokinetic. Remember, kinetic means movement. This is like Reglan, which promotes gastric emptying and decreases the risk of gastric reflux. Antacids, this could be like Maalox or Mylanta. They are quick acting but short-lived relief. They neutralize the hydrochloric acid, and really taken 1 to 3 hours after meals and at bedtime is the best time to use them. You'll see a lot of people that really like pop these, is what we call them, like popping the antacid and they take it frequently because really they are short-lived. This is useful for a patient with mild intermittent heartburn, not the long term. Antacids are not effective in relieving symptoms or healing lesions in patients with moderate to severe GERD, frequent symptoms, and documented esophagitis. So surgical therapy for GERD, it's really performed as needed if they've failed any kind of conservative therapy. Maybe they have medication intolerance. They have what's called Barrett's metaplasia, which is cancerous cells, or esophageal stricture and stenosis, or chronic esophagitis. These are kind of called fundoplications. They take the fundus of the stomach, which is basically used to support and reinforce the LES. the barrier between the stomach and the esophagus, which reduces the amount of reflux. So postoperative care for these surgeries, which some patients can actually get these outpatient because they can do it laparoscopically, but patients can be at higher risk for are hospitalized after the procedures. Those usually are people with prior upper abdominal surgeries or those with like comorbid conditions such as cardiac disease, obesity, maybe sleep apnea, things that they need to watch for. Prevention of respiratory complications, so small percentage of patients actually experience complications, which really can be anything from gastric or esophageal injury, splenic injury, pneumothorax, perforation, bleeding, infection, bloating, and pneumonia. So we're going to try to prevent those. We're going to look at maintenance of fluid and electrolyte balance, prevention of infection, pain medications, and medications to prevent nausea and vomiting. So these patients are not going to be given any food until peristalsis returns, which is the movement of the stomach. So you're going to listen to bowel sounds, things like that, to make sure that their stomach's working before we give them anything. We're going to start with fluids to make sure they can tolerate and gradually add solids. Normal diet really can take anywhere from weeks to months because we're going to add the diet so gradually. Patients must avoid gas-forming food and must chew their food thoroughly. So they actually will tell them to count how many times they chew their food. Peptic ulcer disease, or also known as PUD, is the erosion of the GI mucosa resulting from the digestive action of hydrochloric acid and pepsin. Really, any portion of the GI tract that comes into contact with gastric secretions is susceptible for ulcer development. If you think the gastric content and secretion is so acidic that any portion of the GI tract that's not used to those high acidity levels can develop peptic ulcers. Those at high risk for peptic ulcer is H. pylori, which is the big one, medications such as NSAIDs, smoking, and bile reflux or GERD. Peptic ulcers can really have a variety of stages. So it could be erosion, which you can see in this picture, just kind of goes through that first layer. You can have an acute ulcer, which goes through the submucosa, and then you can have those chronic ulcers that goes through all the layers, and it can have scarring. Both the acute ulcer and the chronic ulcer may penetrate the entire wall of the stomach. Etiology and pathology, the destroyers of the mucosal barrier. The first one really is H. pylori or Helicobacter pylori. It produces an enzyme called urease, which mediates inflammation, making mucosa more vulnerable. Approximately 2/3 of the world's population is actually infected with H. pylori. It's a gram-negative bacteria. Really, the response to H. pylori is likely influenced by a variety of factors, including genetics, environment, diet. The other people that are high risk are people that use large amounts of aspirin and NSAIDs. The use of NSAIDs is responsible for most cases of non-H. pylori peptic ulcers, and this can cause abnormal permeability in the inhibiting synthesis of prostaglandins. So as people age and have more aches and pains, they use more NSAIDs, so they are also at increased risk. Other destroyers of the mucosal barrier are corticosteroids, which decrease the rate of mucosal cell renewal. So it actually slows the healing of that mucosal barrier and decreases the protective effectiveness. And lifestyle factors, a big one, alcohol. Other ones, coffee. So sorry, as most nursing students, we drink a lot of coffee, and a lot of nurses drink a lot of coffee. So that actually puts them at higher risk for the PUD. And then smoking and physiological stress. Drug therapy for PUD is a lot similar to GERD. Our first one is the H2 blockers, which really promote ulcer healing. PPIs, which are going to reduce the gastric acid secretions, helping to maybe less irritate that ulcer and allow it to heal. Antacids, which are going to neutralize the hydrochloric acid in the stomach, and usually actually decreases the pain. And antibiotic therapy, really to eradicate the H. pylori infection. A lot of people they call it the triple drug therapy. It is a proton pump inhibitor and 2 antibiotics. Nutritional therapy for PUD, a lot of diet modifications. Food and beverages that are irritating the patient are avoided or eliminated. There's no standard recommended dietary modification really put forth for PUD, but food that commonly cause gastric irritations really include the hot, spicy foods, pepper, carbonated beverages, alcohol, caffeine-containing beverages, and like broth can actually irritate them as well, especially those of like meat extract. So bland diet may be recommended, and 6 small meals a day are really recommended during the symptomatic phase. Large meals can really irritate that ulcer. There are 3 major complications of PUD, and really they are all considered emergency situations. You have hemorrhage, perforation, and gastric outlet obstruction. The first one is hemorrhage. It is the most common complication of PUD, and it develops from an erosion of granulation tissue found at the base of the ulcer during healing, and also the ulcer through a major blood vessel, so you're going to see lots of bleeding. Duodenal ulcers are the greatest percentage of upper GI bleed episodes, really more than gastric ulcers could be. Next one is perforation. This is the most lethal complication of peptic ulcer. It's common in large penetrating duodenal ulcers that have not healed and are located on posterior mucosal wall. So here's a picture of a duodenal ulcer on the posterior wall penetrating into the head of the pancreas, resulting in what we call a walled off perforation. Perforated gastric ulcers often are located on like the lesser curvature of the stomach. Mortality rates are higher with perforation of gastric ulcers, especially older age of the patient with gastric ulcer, who often have other concurrent medical problems, and the use of many meds across really account for the high mortality rate. So the ulcer really penetrates the serosal surface with spillage of contents into the peritoneal cavity. This is really dangerous. This can lead to what we call peritonitis as well. The size proportional to length of time of the ulcer existed. Large perforations need immediate surgical closure. The small little perforations really seal themselves and symptoms may be resolved. Spontaneous sealing occurs as the result of fibrin production in response to perforation, and this can lead to fibrous fusion of the duodenal or gastric curvature to adjacent tissue, mainly in the liver. So it fixes itself basically. But this can cause like strictures that can obstruct the flow of intestinal contents in the passage of stool. So it's both a great thing, it's sealing its own perforation off, but then the stricture really causes like the scar tissue to stricture into that area, which constricts the bowel. Clinical manifestations, usually a sudden dramatic onset of pain. The initial phase is 0 to 2 hours after the perforation. This pain is not relieved by food or antacids or really anything else. You'll really see sudden severe abdominal pain and rigid board-like abdomen. That's a big one. The rigid board-like abdomen, really the contents are entering the peritoneal cavity from the stomach or the duodenum, and it really contains like air, saliva, food particles, hydrochloric acid, pepsin, bacteria, bile, and pancreatic fluid and enzyme. As that fluid moves into the abdominal cavity, you'll see things such as hypovolemia or low blood pressure. This really occurs to the result of third spacing, which the third spacing is when the fluid moves into the area where it's not supposed to be, causing fluid imbalances. That pain will spread throughout the abdomen to their back as that fluid moves into the abdominal cavity. You'll see the shallow, rapid respirations, tachycardia, and a weak pulse. This is the big one. Bowel sounds will be absent, and they'll have nausea and vomiting. Therapy for perforation: NG tube is placed into the stomach. We're going to continuously suction out. That placement of the tube near the perforation site really facilitates decompression, which helps with that rigid board-like abdomen. We're going to look at fluid replacement when it comes to that third spacing, IV fluid, or blood transfusion as needed. Broad spectrum antibiotics, if you're thinking you've got gastric content all of a sudden going into the entire bowel cavity, we're going to see maybe even some peritonitis or infection of that bowel cavity, so we want to prevent that with antibiotics. Pain medication, super painful obviously, and then they need to go up in and actually repair, either open or laparoscopically. Sometimes if it's not as emergent, they'll try to laparoscopic first, but if it is an emergency, they will do an open surgery. This is a nice little picture of peptic ulcer disease. Upper GI bleeds, there's a couple of different types, but really depends on the bleeding origin. Is it venous? Is it capillary? Is it arterial? A massive upper GI bleed is the loss of more than 1,500 mils of blood or a loss of 25% of intravascular blood volume. That's a huge, massive amount if you think about it. So there's different kinds of the upper GI bleeds and different types. You have the obvious bleeding, such as hematemesis. This is bloody vomitus, and it usually appears as like fresh, bright red blood, or what we call coffee ground blood. Bleeding from an arterial source is profuse. Blood is obviously bright red, and that bright red color indicates that the blood has not been in contact with gastric hydrochloric acid secretion. So it's usually higher in the GI tract. If it does come out as the dark coffee ground vomitus, it usually indicates that it has been in the stomach for some time. The darker it is, usually the longer it's been in contact with those GI secretions. The other option is melena. So those two, the hematemesis was the upper coming out, vomiting. Melena is black tarry stool. The longer the passage of the blood through the intestines, the darker the color. So if it's lower in the GI, it might be more bright red. If it's higher in the lower GI, it's going to have that dark, like brown, and it has a specific smell to it too. This is usually caused by a breakdown of hemoglobin and a release of iron. So melena would indicate a bleed higher up in the GI tract. So you can also have occult bleeding. Occult really means hidden. It is undetectable by appearance. It's small amounts of blood in the gastric secretions, maybe vomitus or stool, and it's detectable by like a specific Guaiac test that we can do. So common causes of bleeding in the esophageal origin, really sometimes the cause of the bleeding is not always easy to determine. Bleeding from the esophagus is most likely due to chronic esophagitis, maybe a Mallory-Weiss tear, or esophageal varices. Bleeding peptic ulcers also account for about 40% of cases of like upper GI bleeds. You could also have drugs, either prescription or over the counter, that are causing of an upper GI bleed. This can be maybe like NSAIDs, aspirin, corticosteroids. Approximately 25% of people taking long-term NSAIDs, such as ibuprofen, will develop maybe an esophageal diagnosed ulcer, and about 2 to 4% of these will bleed. Aspirin and NSAIDs and corticosteroids can cause irritation and disruption of the gastroduodenal toxicity, and even low-dose aspirin, the like baby aspirin, which is the 81 milligrams, is associated with a risk for GI bleed. Many over-the-counter like preparations contain some kind of aspirin. So careful history of the commonly used drugs is necessary when upper GI bleed is suspected. For example, somebody with a cardiac history, maybe they say take a baby aspirin every day, and this put them in a higher risk for a GI bleed. Other ones that are big, alcohol. Alcohol can be a big cause of both Mallory-Weiss tears from the vomiting and esophageal varices, and cigarettes. PUD is also a common cause. Bleeding ulcers account for about 40% of upper GI bleeding, and it's usually related to H. pylori. Gastric cancer can also cause issues. It's really like the tumors or vascular lesions that can cause issues. Stomach cancer causes steady blood loss as it grows and ulcerates throughout the mucosa and blood vessels located in its path. So it's kind of like a slow bleed. And then you could also have hemorrhagic gastritis. Polyps, really these are stress-related mucosal disease, also known as SRMD. It is also called physiological stress ulcers. It occurs in patients with severe burns or trauma or after a major surgery because they have so much high stress it causes increase of the acid, which can cause stress ulcers. Erosion of greater number of superficial blood vessels occurs with SRMD than like peptic ulcer disease. So Protonix is given to help reduce the risk of this. So a lot of patients are on Protonix, and that is to prevent these kind of stress-related mucosal disease and polyps. So really, endoscopy is the primary tool for diagnosing source of bleeding. They're going to go in and find that bleed. Laboratory studies, this could be like a CBC or complete blood cell count. This is where they might look at an initial hematocrit, which may be normal and not reflected the loss until like 4 or 6 hours after replacement. So it's not going to be like the best initial tell, but 4 to 6 hours after it can be. BUN, which is elevated during significant hemorrhage because blood proteins are broken down by the GI tract, and so the kidneys are going to try to process them. So you might see a change in the BUN. And you're also going to check CMP for electrolytes and different issues as well. We also can do things like ABG, which is arterial blood gas, which is going to be a more initial tell of loss, and typing and cross-matching for possible blood transfusions. This should be done always just to be ready if something goes wrong. Other options is to do look at the vomitus and stools to check for for example, the GUIX. So we're going to check for the present of occult hidden blood, or maybe even gross, which is the visible blood. And then a urinalysis, specific gravity, indications of a patient's hydration status, which is going to tell us if they're dehydrated, which could be a sign of blood loss. So immediate physical examination with emphasis on respiratory status, blood pressure, rate and character of pulse, and peripheral perfusion with capillary refill. Think ABCs. You're going to look at airway, breathing, circulation. Those are the most emergent things that you're going to assess. So you also might do an abdominal examination, which is really going to tell the presence or absence of bowel sounds, and a tense, rigid abdomen. So you're going to really look at that belly, check your vital signs, and that's going to tell you a lot of things. Signs of hypovolemic shock, which is the most concerning complication. That means they've lost too much blood. You're going to see a decrease in blood pressure, a decrease in pulse pressure, tachycardia, which is the high heart rate, cool, clammy skin, decreased level of consciousness, decreased urine output, which means they don't have enough blood to actually circulate the kidneys, and slow capillary refill. You're going to check that cap refill because if their blood is not getting to the extremities, you're going to see that slow cap refill. Hypovolemic shock is basically when there's not enough oxygenated blood or volume of blood available to for the body to function properly. So it is a medical emergency. So we're going to focus on fluid replacement and blood replacement. This is a great picture of exactly what we're going to look for. Sometimes we're going to emergently just pour blood and fluid into these patients to keep their system working long enough till we can go in and fix what the issue is or where the bleed is. Drug therapy for upper GI bleed. During the acute phase, drugs used are really to decrease bleeding, decrease hydrochloric acid secretion, and neutralize that hydrochloric acid that's already there. So that's going to be, again, your H2Rs and your PPIs. Other drugs that can be given are vasopressin and epinephrine. That's going to be used to really help move their blood flow around to really keep the system from going into that hypovolemic shock. So surgical therapy for these upper GI bleeds, it's really indicated when bleeding continues regardless of the therapy provided. Site of bleeding is determined choice of operation. So that really tells us, are we doing upper or lower scope? Surgeon may consider the age of the patient. Mortality rate really increases considerably in these patients older than 60 years old. And a high percentage of patients will actually have another massive hemorrhage within 5 years after the first bleeding episode. So there is this recurrent thing that can occur. So there is a big push for discharge teaching to prevent these patients from coming back in and needing another kind of high-risk surgery.